All right, good morning, everybody. Welcome back to Grand Rounds. I'm your host for Grand Rounds this year. I'm Stephanie. I'm one of the medicine chief residents, so you'll be seeing myself or one of my other colleagues throughout the year. Today, we have Dr. Steve Liang from the Division of Emergency Medicine, Internal Medicine, Infectious Disease, kind of the triple threat to talk to us about monkeypox. It's kind of eerie in that this is about 2.5 years ago that we gathered over in the Clopton Auditorium to hear about another emerging pathogen. Hopefully today's topic is not going to be as prevalent over the next few years, but nonetheless, we will be prepared. So thank you, Dr. Liang, and we'll hand it over to you.
Thank you very much, Stephanie. I appreciate that introduction. Real honored to be here this morning to present Grand Rounds on monkeypox, so the changing landscape of emerging infectious diseases. I have no relevant disclosures here. As far as our objectives for today, I'd like to define what an emerging infectious disease is, how it arises, and why it should matter to clinicians. Next, I'd like to talk about the clinical presentation, the management, and the prevention of monkeypox. And finally, I'd like to kind of place monkeypox within the context of the evolving landscape of emerging infectious diseases. So, emerging infectious diseases, what comes to mind when you think about that? Well, this is kind of the technical definition for it set by the NIH. It's an infectious disease that may have newly appeared in a population where it has existed, but is rapidly increasing in incidence or geographic range, where it is caused by one of the category A, B, or C pathogens labeled by the NIH. And just for your reminder, as far as category A, these are all the ones that we worry about the most in the infectious disease world. They're highly disseminatable, high mortality, major public health threat. Lots of things need to be done to prevent their spread. So this includes your usual bad actors, anthrax, botulinum toxin, the plague, smallpox, as variola major, distinct cousin of our monkeypox virus that we'll be talking about today, tularemia, and of course, Ebola, our viral hemorrhagic fever. These are the other categories. You don't need to spend a lot of time looking at them. So I guess when I thought about emerging infectious diseases kind of growing up as a college student and later as a medical student, first image in my mind comes to mind is obviously Dustin Hoffman in his BL4 suit. And then, many years later, the movie Contagion, probably more accurate depiction of what a pandemic would look like. And then now, as far as emerging infectious diseases, this is the real thing that we've seen in the last 10 years. Obviously, Ebola, the West Africa outbreak several years ago, and then the one that we have all lived through together as healthcare workers, COVID-19. When I think about emerging infectious diseases, I think that this slide actually summarizes it really well in terms of the factors that predispose to this. So we think about changes in demographics and behavior. So yellow fever and dengue fever reached the New World through the slave trade, changes in demographics and behavior. Environmental change, climate change. We live in a wet and warmer world these days with flooding, high rainfall. These are all opportunities for vectors that transmit infectious diseases to spread to new areas. Breakdown in public health surveillance, as well as measures and prevention. We saw this in Africa with war, famine, poverty, social inequality, and a lack of political will that led to the West Africa outbreak of Ebola. Microbial adaptations, when viruses find a way to adapt and expand to new vectors, vectors that have a wider geographic spread, which we saw with chikungunya, that can lead to an emerging infectious disease. The changing ecosystem, the smaller world that we live in terms of travel, the intent to harm, which we saw in 2001 with the anthrax attacks, and finally changes in industry and technology. All these things together or in isolation can lead to the emergence of an infectious disease. So the last 20 years, you will recognize this hit list of organisms over the last 20 years. And the thing I want to highlight here is that the predominant organisms have been zoonoses. So these are infections that are transmitted from animals to humans. And all of them, as you might also note, are viruses. So the original SARS-CoV-1 in 2004, followed by SARS-CoV-2, which we know well from COVID-19, Nipah virus, H1N1 flu, Ebola virus, MERS, avian influenza. And then we also have diseases that are transmitted through vectors like mosquitoes. So West Nile virus, chikungunya, and Zika virus. This is to remind you why it matters to all of us as clinicians, because we live in a smaller and smaller world, and the distance between us and any other point in the on the globe is probably less than 24 to 48 hours. The traffic between the United States and the rest of the world in 2019, 244 million travelers between the US and the rest of the world. So there is a lot of traffic and a lot of opportunities, for infectious diseases that were once isolated in very remote parts of the world to reach the United States and other countries. This is to remind you, that only the dead have seen the end of war, and I like to think maybe a less well-known statement is that only the dead have seen the end of infectious diseases, and to remind you again that this is something that we all see as frontline healthcare providers, and this is why emerging infectious diseases should matter to all of us. So monkeypox, let's talk a little bit about the past before we talk about the current outbreak. So to give you kind of our baseline understanding, so this is pox virus 101. These are viruses within the family of Poxviridae. This large virus here is our pox virus. Let me put up my pointer here. So our pox virus here, obviously the coronavirus, which we know well, is much smaller virus down there. But the pox viruses, the ones that really matter to us are 4 specific genera in particular. This includes orthopox virus, which includes variola major, the etiological agent for smallpox, monkeypox, cowpox, and vaccinia. And then some of these other genera. The one that I want to highlight here is the molluscopox virus, the virus that causes molluscum contagiosum. But we will definitely stay today. Our focus will remain on orthopox viruses. So as far as the orthopox viruses, the thing to note here is that 3 of the 4 orthopox viruses are zoonoses. So again, viruses that are transmitted from animals to humans. These include monkeypox, cowpox, and vaccinia. Variola major, the virus that causes smallpox, has no known animal reservoir. And that's the reason for the success of the smallpox eradication efforts in the 1970s and 1980s, because we were able to eliminate, we believe we were able to eliminate all human cases there and prevent any kind of reservoir within humans. There were no animals for it to live within. An important property of orthopox viruses is that infection with one orthopox virus actually conveys cross-reactive protection against the other orthopox viruses. And the story is now obviously well ingrained within medical history lore. The story of Edward Jenner, who identified the cowpox lesions on the milkmaid, and that milkmaids did not get smallpox, was able to then harness some purulent material from that lesion and inoculate the son of his gardener, and then expose the son of the gardener a couple of weeks later to smallpox and demonstrate the prevention of smallpox with this cowpox vaccine. There were definitely instances of vaccination for smallpox that predated that, but this is obviously the one that is well ingrained within our history. Probably more important and more significant is the World Health Organization's smallpox eradication effort in the 70s and 80s with the vaccinia vaccine, which basically eliminated all cases except all cases of the virus within humans. Currently, the only viruses that we know of remain within research laboratories. As far as monkeypox virus, this was first identified in 1957 and actually outside of Africa. This was identified in captive monkeys in Copenhagen. Throughout the 1960s, we saw sporadic outbreaks within non-human primates in zoos, nature reserves, research colonies in Europe and throughout North America. It was thought that the reservoir actually for this virus was not monkeys, in fact, but actually small mammals that originated from West Africa and Central Africa, including the rope and sun squirrels and the giant pouch rat here, as well as dormice. The first human case of monkeypox was identified in 1970. This occurred in a small village in Bukenda, Democratic Republic of the Congo, previously Zaire, and this was identified 2 years after the last case of smallpox. This involved a 9-month-old unvaccinated child, and this hopefully sets up for kind of the emergence and the story of emergence of this virus over time. Over the next 10 years, there were 47 human cases of monkeypox identified across West and Central Africa. And predominantly this impacted children under the age of 10. So 83% of these cases were under the age of 10. They occurred primarily within the tropical rainforest areas of Central and West Africa, where people were in close proximity to wild animals, and wild animals can oftentimes be a source for food. What is interesting here is that only 9% of those cases had the vaccine scar. So this is an unimmunized unimmunized population of folks who developed monkeypox infection. I also want to highlight the mortality rate, 17%. So there are 7 deaths of the 47 human cases. These are the first images that came out of these outbreak evaluations. And obviously, a pretty, pretty astonishing case of rash that looks a lot like smallpox. It's very firm, deep-seated rash that involves the entire body, also associated with significant lymphadenopathy, as you see here in the inguinal nodes, as well as the cervical nodes. And I want you to kind of ingrain that within your mind, the lymphadenopathy that is associated with this infection. This is a child who had corneal ulceration from monkeypox virus a year later. So corneal infections can actually lead to scarring and also permanent blindness. Throughout the next 10 years, the World Health Organization had a special surveillance program, part of the smallpox eradication program, that identified 338 cases. Of these, about 20% were moderate illness. So these are patients who had 25 to 99 lesions requiring nursing care, and an astonishing 70% who had severe illness, so more than 100 lesions and requiring intensive medical care. I also want to highlight the demographics. So you may not be able to see it as well, but basically what this shows is that the predominance is, again, within young people. Children under the age of 15 were primarily impacted by monkeypox virus during these outbreaks. The complications were not insignificant. These included bacterial skin infections, pneumonia, keratitis, and corneal ulcerations, which we saw in the previous image, and very rarely encephalitis. The case fatality rate was 10%, highest particularly in the youngest kids under the age of 2. Now, compared it to smallpox, where the mortality rate historically, where the case fatality rate was historically over 30%. They conducted close surveillance of close contacts and identified a secondary attack rate of 7.5%. What is interesting to note here is that, as you would expect, those who were close contacts and were unimmunized against smallpox previously were at higher risk for developing monkeypox as a close contact to a case. In contrast, those who were vaccinated had a far lower attack rate. So for a combined attack rate of about 7.5% among close contacts, compare that to smallpox, where the attack rate can be anywhere from 37 to 88%. This led the authors to conclude monkeypox is a poorly adapted virus for sustained transmission and probably does not pose a significant public health problem at this time. And that was until a couple of years later. So the first case of monkeypox outside of Africa, this is the USA 2003 outbreak. This involved 47 confirmed or probable cases across 6 states, including Missouri. What they identified as the risk factor was contact with infected prairie dogs. This is a very different outbreak compared to what we saw in Africa. In this story, prairie dogs were housed near small mammals imported from West Africa, including rope squirrels, giant pouched rats, and dormice. These prairie dogs were sold as pets prior to symptoms. And basically humans interacted with the prairie dogs, which were infected either through petting or handling. Humans were scratched or bit, or in some cases, like I said, just being in close proximity with an infected prairie dog. This outbreak was localized primarily to households, so pets in households, as well as occupational settings, including vet clinics, pet swaps, and pet stores. Of the 34 confirmed cases, 71% were over the age of 18 years. So this is, again, a very different demographic for monkeypox. So these are now adults primarily who are impacted. Only 15% had severe illness in comparison to the cases that we saw in the DRC. About a quarter required hospitalization for more than 48 hours, and there were no deaths. So mortality rate was non-existent, thankfully, with this outbreak. There was no association between prior smallpox vaccination and disease severity or hospitalization. And thankfully, there was no documented human-to-human transmission with this outbreak. So a very different looking type of monkeypox presentation. And this leads us to a tale of 2 clades. You may have heard about this already, but very astute folks looked at the cases that occurred in West Africa, Central Africa, and now the United States. And what they saw is that the West African US cases were far milder in severity compared to the Congo Basin and Central Africa cases. They had a lower case fatality rate. There was non-existent secondary transmission, and the isolates, when placed within animals, were less virulent compared to the Central African viral strains. In 2005, genomic analysis confirmed that there were 2 distinct monkeypox virus clades, our clade 1 and our clade 2, which were just recently renamed by the World Health Organization. So clade 1 were viruses, monkeypox viruses originating from the Congo Basin or Central Africa, and clade 2 from West Africa. From this point on, I will refer to both as clade 1 and clade 2 rather than the geographic distributions. So for the next years, we understood kind of how monkeypox is transmitted. First from animals to humans, and then between humans with close contact. Occasionally, there would be travel-associated cases. And again, the transmission within non-endemic settings would be from person to person, potentially through close contact with either skin lesions, body fluids, fomites such as linens and clothing surfaces, et cetera. But for the most part, a forgotten or even ignored disease outside of the African continent. And again, a neglected disease. 1970 to 2008, there were multiple cases and outbreaks throughout 10 African countries, most notably the DRC, as well as neighboring countries in Central Africa, Nigeria, notably in 2018, and within West Africa. In DRC, monkeypox was considered endemic. So clade 1 was endemic in the DRC. And between the years of 1981 to 86 and 2005 to 2007, there was a reported 20-fold increase in incidence of monkeypox virus cases. I think that this is the bellwether when things started to change. In 2017, a large outbreak that occurred in Nigeria. So 122 confirmed the probable cases across 17 states. We're not talking about isolated outbreaks. We're talking about a large-scale, widespread outbreak. Nigeria had its last case of monkeypox prior to this in 1978. Like I said, this was again the first large-scale clade 2 outbreak in West Africa. And these are the demographics. The median age was 29 years. So again, now involving adults for the most part, though still affecting children as well. A wide geographic distribution, both zoonotic as well as secondary human to human transmission. And then alongside that, multiple unrelated clusters reported within households as well as within one prison. There were only 7 deaths in this outbreak. 4 of those involved immunocompromised individuals with HIV/AIDS, and the case fatality rate was 6%. And I think that this was probably a potential signal for things to come. So we generally had a pretty good understanding for why monkeypox virus was starting to emerge once more. And part of this is probably the waning immunity against orthopox viruses following the smallpox eradication in the 1980s. It's probably also related to increased exposure between humans and animal reservoirs tied to deforestation, war, civil unrest, poverty, all of these things which drive populations to find shelter closer to animal reservoirs, as well as which also become animal sources for food and sustenance. There's also an increased human transmission that was seen. And then finally, like we talked before, the world is getting smaller and smaller. So more travel and commerce between all parts of the world probably promoted the emergence of this infectious disease. And then finally, improved diagnostics and reporting. We're able to diagnose it and test it better. And you have to wonder, 50 years after the first case of monkeypox was identified, what was going to happen. However, at that time, the world turned its attention eastwards towards a cluster of undiagnosed pneumonia in Southeast Asia. 2 years later, here we are, monkeypox 2022. So as you know, this is now a multinational outbreak, the largest outbreak of this virus to date. These are the cases reported by the World Health Organization. There have been more than 54,000 laboratory confirmed cases across the world. Predominance has been primarily in Europe as well as the Americas, North and South. 18 deaths have resulted to date. This is the epi curve, which basically demonstrates, again, the predominance of cases within the Americas as well as Europe. The first case of monkeypox virus was reported in the UK on the 7th of May, followed by the first case in the United States on the 19th of May. On the 23rd of July, World Health Organization declares public health emergency of international concern regarding monkeypox virus. Here in the United States, we have the most cases reported in the globe currently in this outbreak. There have been 21,274 laboratory confirmed cases as of yesterday across all 50 states. This is our epi curve here in the United States. We saw the first cases, like I said before, in May and June, that gradual rise within July and August, and we are hopeful we are starting to see a downtrend in cases here in the United States. with effective measures and the vaccine becoming available. The breakdown for this current outbreak is primarily among men in the young to middle age range, and it affects all races. The population of gay, bisexual, and men who have sex with men has been disproportionately impacted by the outbreak. However, I must emphasize that the major risk factor for monkeypox transmission has been close personal contact with cases, irrespective of age, race, sexual orientation, or gender identity. The current transmission has been accelerated within sexual networks, which is a new finding, as well as historically within household contacts. To date, there have been few women or children impacted by the current outbreak here in the United States. However, as I hopefully have demonstrated to you with past outbreaks in other parts of the world, that children and women are not immune. This is a disease that is transmitted through close personal contact with cases. To emphasize again, the nature of human to human transmission, the virus is transmitted through contact with body fluids, scabs, and skin lesions. It can also be transmitted by contaminated objects, so fomites, fabrics, linens, bedding, and so forth. And then finally, through respiratory secretions, close face-to-face contact. Thankfully, in the current outbreak, there have been no reported long-range transmission events or airborne transmission events. However, we still treat it as such as a precaution as we're learning more. The one thing I want to highlight down here is that folks are most contagious when they present with the rash. When they have that prodrome, they are possibly contagious, but certainly they are most contagious when they have the rash. As far as the clinical presentation, the incubation of the disease ranges anywhere from 5 to 13 days. The prodrome can include fever, headache, fatigue, myalgias, and most notably lymphadenopathy. Remember those images from before. Severe cervical as well as lingual lymphadenopathy is almost a hallmark of the disease in comparison to other virus diseases. This usually lasts for about a day to 5 days and then progresses to the rash, which can be either painful or itchy. It's also important to note that the prodrome can be limited, short, or even absent in some cases. As far as what we seen here in the United States, rash has been the predominant presentation. 97% have the rash. And then you see these other symptoms. Highlight again that lymphadenopathy, almost to 60% with lymphadenopathy. And quite novelly, we have seen a large number of atypical presentations, patients who present with rectal pain, rectal bleeding, tenesmus, and proctitis. So you must be aware about that when you consider the differential diagnosis of monkeypox virus, and then very rarely conjunctivitis. The classic textbook rash begins with a macule that then progresses to papule, a vesicle, then a pustule. The pustule scabs, falls off, and then you get desquamation as part of that process, and then you get new skin that grows underneath there. The lesions are described as being firm, deep-seated, potentially umbilicated, and painful. So I really want to kind of ingrain that description: firm, deep-seated. So not a superficial infection, but actually almost like a nodule in some instances. It starts usually on the face, sometimes in the mouth, then progresses downwards and outwards towards the arms, the extremities, the arms, the legs, and then the hands and the feet. They can involve the palms and soles as well. These lesions are contagious until they're crusted over completely and the skin is healed underneath. So these folks can oftentimes require isolation for a long period of time. As you can imagine, this could take anywhere from 2 to 4 weeks potentially of isolation before they're considered not contagious anymore. This is just some more images released from the United Kingdom, basically showing the progression, starting first with the vesicle, then a pustule, then this umbilicated pustule. So you see that umbilication is a pretty good mark for this disease. It then ulcerates, it crusts, and then the crust scabs and falls off. So this partially removed scab here is the conclusion of the disease. These are some images from various outbreaks. So from 2003, you'll recall that prairie dog outbreak in Wisconsin and Midwest United States. These are lesions that were at the site of inoculation. So I remember that this is related to pets. So pets bite, and this is a child who was bit on the finger and developed a lesion there. This is probably a scratch related to that prairie dog as well. This then progresses to a disseminated rash. So these disseminated lesions can look more vesicular and pustular in nature. And then you see a couple more of these kind of classic lesions, particularly this one with the umbilicated lesion there. These are images from the current outbreak. So we talked again about where it starts, oftentimes on the face. In this case, a person with a lesion on the chin that then progresses downwards and outwards, involving the back, the palms, the soles of the feet, and so forth. During the current outbreak, we have noticed some new features to the disease. So many of our patients have presented now with genital or perianal lesions or rectal pain or proctitis, oftentimes without a visible lesion. And then after that, then progressed to the classic diffuse rash. The lesions have also been fewer and smaller in number. And I will warn you in advance, as far as these images, we're all adults, but this hopefully helps you understand what exactly we're seeing as far as the lesions. So again, these umbilicated lesions that occur oftentimes in the GU space, sometimes kind of these raised lesions with pustular appearance, but also ulcerated lesions. And then again, these umbilicated lesions here. Some other images as far as, again, that umbilicated lesion here and here, kind of these small lesions, very kind of nondescript. So you really have to do a good head to toe skin exam in these patients. And then these are the perianal lesions that have been seen as well. I want to just show a couple more images as far as oral lesions. So a vesicular lesion within the lip, an ulcerated lesion on the lip here, kind of that almost has a sort of umbilicated / appearance here on the tongue. It can cause tonsillitis, it can cause conjunctivitis, it can cause infections near the eye. So if you see this near the eye, you must be concerned for potential corneal involvement because of long-term consequences of a corneal infection. A differential diagnosis these days is wide because of where these rashes are located. You must consider HSV, VZV, molluscum contagiosum, syphilis, chancroid, LGV, disseminated gonococcal infection, and disseminated fungal infection. So a really wide internal medicine differential. For those who are presenting with rectal pain or proctitis, the differential must also include HSV, gonorrhea, chlamydia, including LGV and syphilis. In many cases, there have been co-infections with other sexually transmitted infections. It's important to screen for HIV because of this high-risk setting. You can also consider non-infectious causes because these lesions can look like a lot of other different things, including Behçet's, recurrent active stomatitis, trauma, malignancy, a drug eruption, etc. So a lot of potential masqueraders here. Before the current outbreak, the big conundrum was trying to differentiate monkeypox versus primary varicella or chickenpox. And these are just a couple of the characteristics that differentiate the two. With monkeypox, the lymphadenopathy is fairly characteristic. You do not see that with smallpox or chickenpox. And then the lesions with monkeypox are, again, buzzwords: hard, deep, well-circumscribed, umbilicated, that deep-seated lesion compared to the lesion of chickenpox, which is superficial, has irregular borders, and the textbook quote of dewdrop on a rose petal. With monkeypox, most of the lesions are usually at the same stage, though that is not always consistent, but usually in the same stage. In comparison with chickenpox, these lesions can be in multiple stages. So you can have vesicles next to scabbed over lesions, etc. Just to kind of underscore the wide differential possible with these lesions, they can look like a lot of different things. So they can look vesicular here. You may have some initial thoughts about some of these images. I'll just go through these very quickly. So the person who presents with diffuse vesicular rash here, a person with a dermatomal appearing rash here, a person with a painful rash on the shaft of the penis, a person with umbilicated lesions, a person with an itchy rash involving the palms and soles with some scale here, someone who has these lesions that appear more distal, so involving the very fingertips as well as the toes, someone here with this very kind of well circumscribed, almost heaped up lesion here. Let's say this person potentially has HIV/AIDS. And then finally, this lesion here with the kind of ulcerated and scabbed over appearance. And you may have been keeping track. You can kind of test yourself and see if you hit a couple of these, but these are just part of the differential diagnosis for monkeypox virus. As far as testing, we're very fortunate that we have a PCR now that tests for orthopox virus and monkeypox virus DNA. For those who are presenting with rash, you want to obtain 2 dry swabs, and this is unique to our commercial lab that we're using. 2 dry swabs should be obtained from 2 to 3 lesions, and you really have to rub these lesions pretty vigorously. The intent is to try and gather squamous cells, skin cells on the swab itself for testing. This can lead to unroofing and also fluid. All those things are good. You want to send all that, but you have to swab these lesions pretty vigorously. For those who are presenting with proctitis or rectal pain, 2 dry swabs from suspected site. Remember, this is a anal swab, but this is not a stool swab. So we do not submit a stool as part of that specimen. There are also other tests available. There's a serology, probably has limited utility within the current outbreak. And then finally, you can find some non-specific changes on labs. So an elevated transaminase, elevated white cell count, low platelet count, hypoalbuminemia, and so forth. The management and prevention. Thankfully, the disease is primarily mild and self-limited in most individuals. The prognosis is guided by prior vaccination, baseline health, and concurrent comorbidities. There is no specific monkeypox-specific therapeutic. However, we are using many smallpox therapies, which may be beneficial in the current outbreak. You probably have heard about tecovirimat or TPOXX. There are also other antivirals that have been considered, including cidofovir and brincidofovir. Vaccinia immunoglobulin, which was historically used for folks who received the classic smallpox vaccine, the ACAM 2000, developed adverse effects for that. This is only available through the Strategic National Stockpile, as are the other agents on this list. And then finally, the vaccines, Jynneos, and like I said, ACAM 2000. And we'll go into each of these. As far as TPOXX or tecovirimat, this is an antiviral that inhibits P37, an envelope protein on the virus that is involved with replication and egress from an infected cell. The data for this antiviral and monkeypox virus is extremely limited. There is suggested mortality benefit within animal studies, and there are now emerging case reports and small case series that suggest benefit in terms of reducing illness duration and viral shedding over time. The CDC currently has an expanded access IND protocol that was just started less than a month ago that allows availability for this antiviral for use in primary or early empiric treatment, as well as post-exposure prophylaxis. So we're using this under an expanded access authorization for adults and children. We have the PO and IV version. As far as when you would use this antiviral, we've been reserving it primarily for severe disease, including pain, as well as for those with high risk for severe disease, so the immunocompromised. We saw in young children and other outbreaks that they have been disproportionately impacted, the pregnant and breastfeeding, those with skin conditions, and those with lesions in kind of unusual locations that are a high risk for progression, like the eyes, the mouth, as well as the genital and anal areas. Empiric treatments can be appropriate in some cases. We have used it, I believe, here in the hospital for patients presenting with severe pain related with lesions in the GU area. And the benefit is thought to be greatest when it is started early, as with many antivirals and antimicrobials. The drug is generally well tolerated. The oral agent, headaches, nausea, abdominal pain, fatigue, myalgias for those who receive the IV agent, injection site pain, swelling, redness, and headache. As far as how you access this agent, it's currently available through the state public health department. Again, these are all antivirals that are stocked within the Strategic National Stockpile, which was intended for use in the event of a biological attack against involving smallpox, but we are now repurposing it for the current widespread outbreak of monkeypox. Infectious diseases is always there to provide guidance with decision-making and can also facilitate the process of accessing the antiviral. We are currently developing processes with the outpatient pharmacies, both here on campus as well as within the community to reduce the barriers to accessing the drug in the appropriate setting. I would say that if you have a patient who is highly suspicious, who has a highly suspect rash for monkeypox, you may consider obtaining the informed consent at the time of testing, just to facilitate the time to getting TPOXX approved and administered. Those forms can be found here with the CDC. So to talk a little bit about the vaccines. So we have 2 vaccines, Jynneos vaccine and the ACAM 2000. The Jynneos vaccine is a live but modified virus that is replication deficient. And for that reason, it is actually safe in the immunocompromised. It's administered as 2 doses, about a month apart. Traditionally, it's given subcutaneous. However, in the current outbreak and the shortage of doses, there has been an expansion with the intradermal route that has allowed us basically to dilute our stock down so we can give up to 5 doses for every original 1 subcutaneous dose that we had before. The immune response usually kicks in about 2 weeks after the second dose, so it does take a while. The current vaccine, the Jynneos vaccine, is FDA approved for smallpox and monkeypox virus in adults over the age of 18. ACAM 2000 is the more traditional live vaccinia smallpox virus vaccine. This is a replication competent vaccine, and it basically is administered through the bifurcated needle. You may have seen this, where you basically jab the side of the percutaneous area multiple times to induce a take. The immune response takes about 4 weeks. This is currently FDA licensed for smallpox. There is an expanded access authorization for monkeypox. This virus, because it is alive and replication competent, is contraindicated in immunocompromised. The reason why we've leaned towards the use of the Jynneos here, for many good reasons. Obviously, the Jynneos vaccine is a replication deficient virus. There is no take involved. There are fewer adverse side effects, and it's believed to be far safer compared to the ACAM 2000. In contrast to ACAM 2000, we talked about the risks as far as a live vaccine replicating within the lesion there and potential transmission to others, and then also the complications that being associated with being vaccinated with a live virus. In this case, rare cases of myopericarditis. So the vaccines are currently being geared towards post-exposure prophylaxis, or PEP. And this is usually folks who have had known contact identified through case investigation, contact tracing, or risk exposure assessment. It has to be administered within 4 days of the exposure for a maximal benefit, we believe. However, those who receive it anywhere from 4 to 14 days may have reduction in symptoms with post-exposure prophylaxis, but will not prevent the infection itself. There is no demonstrated benefit after symptom onset. Moving onwards, expanded post-exposure prophylaxis is now ramping up in many parts of the country, and this involves vaccination of those who are known or presumed contacts, as well as those who have some of these other risk factors. So someone who's had a recent sex partner within the last 2 weeks who was diagnosed with monkeypox virus, so a high-risk situation potentially there, as well as certain MSM or transgender persons with any of the following within the past 14 days. So sex with multiple partners, sex at a commercial venue, sex and associated with an event, venue, or defined geographic area where monkeypox transmission is ongoing, all in an attempt to try and curb the spread of the outbreak. Pre-exposure prophylaxis is currently reserved for very certain occupational groups, primarily research laboratory workers, in some cases, healthcare workers who are part of a public health or anti-terror type response. The vaccination strategy here in the United States really kind of hinges on a limited vaccine supply. And for that reason, we've tried to focus most of those efforts towards post-exposure prophylaxis, but now spreading out towards the expanded post-exposure prophylaxis I talked about, and finally PrEP. On August 9th, the approval went forward to dilute our Jynneos stocks because of limited doses, allowing for the intradermal route. I have to emphasize again that there is no data yet on the effectiveness of these vaccines in the current outbreak. And there definitely are murmurings and concerns about the degree of protective antibodies that are generated after these vaccines are administered. So definitely keep on top of the data that's coming out. It's fast moving, just like it was with COVID-19. There's been a huge emphasis on the importance of vaccine equity. We saw this with COVID-19. This is even more important now, trying to get those vaccines out to the highest risk populations, both here, abroad, and so forth. We hope that there will be more vaccines available later on this fall. From an infection prevention standpoint, the first thing that you need to do is if you suspect monkeypox virus in a patient, is to isolate that patient. You need to place them in a single room with the door closed. If you're anticipating that this is going to be a patient who's going to require intubation or other aerosol generating procedure, they have to be in an airborne infection isolation room. And also if they're critically ill for that part. As far as the PPE, you should recognize all of this. This is COVID-19 gear, gown, gloves, eye protection, and an N95 respirator or a PAPR in some instances, depending on your ability to don the respirator. Your next step is to notify infection prevention. As far as the potential suspect there, just to try and limit spread within our healthcare setting. The good news about the virus itself is that it's relatively easy to kill. So hospital-grade disinfectants that are EPA registered for emerging viral pathogens, these are all the ones that we use in the hospital presently, are effective against killing the virus within the environment. You want to avoid contact, direct skin-to-skin contact with material present either on the skin of the patient or in laundry or linens. When you see these laundry and linens, you want to bag them, don't shake them. And then finally, isolation in confirmed cases has to continue until all lesions are crusted, the crusts have separated, and there's now new healthy skin underneath that is formed. So that again can take anywhere from 2 to 4 weeks, so very prolonged isolation. In terms of occupational health, thankfully the risk to all of us as healthcare workers is relatively low. To date, there's been only one documented healthcare transmission that's occurred in the UK in 2018. This was a returning traveler from Nigeria. A healthcare assistant who was caring for this patient had greater than one episode of close contact with the patient's bedding and clothing. That healthcare worker only wore a gown and gloves, no mask or eye protection, and subsequently developed monkeypox virus infection as a result. There have been other cases that have been reported in the news as well as within other outbreaks, but these have not been well described or validated. A lot of people ask me about post-exposure prophylaxis for healthcare workers after caring for a patient for monkeypox virus. I want to highlight kind of the high risk and intermediate risk scenarios where we would consider this. So for high risk, someone who's had unprotected skin or mucous membrane contact with a patient's skin, lesions, body fluid, or contaminated materials, or a healthcare worker who has been in a room where a patient has received an aerosol generating procedure without that healthcare worker donning the appropriate PPE. That category of healthcare worker would be offered post-exposure prophylaxis. For the intermediate risk, this is usually someone who's been within less than 6 feet of an unmasked patient for more than 3 hours without wearing at least a surgical mask, some form of respiratory protection, and then healthcare worker who has had clothing contact with this patient's skin, lesions, body fluids, and contaminated materials, wearing gloves, but not a gown. So in those instances, those intermediate risk cases, we would talk to the healthcare worker and we make a shared decision there about whether or not to proceed in terms of the benefits and risks of receiving post-exposure prophylaxis with the Jynneos vaccine. So your take-home pay for today on monkeypox virus. This is an outbreak that is currently driven by clade 2. It is a disease here in the United States that has been subtle, non-classic in presentation. We've seen a predominance of genital and anal lesions, as well as patients presenting with rectal pain and proctitis. You have to keep a wide differential because of this presentation as far as other potential sexually transmitted infections, as well as other viruses. The incubation period for this disease can range anywhere from 5 to 14 days. It's rarely been life-threatening, thankfully so. The transmission is skin to skin, really important. If you suspect this, isolate the patient, get the appropriate PPE on to protect yourselves as well as others. We have antivirals that are being used on almost kind of on an empiric as well as investigational status. As tecovirimat, we reserve that for patients with severe disease that can include pain or high-risk situations. And then finally, post-exposure prophylaxis for high-risk individuals. So this leads me to a final round here, the changing landscape of emerging infectious diseases. How does monkeypox sit within that? When I started putting together this talk, I had obviously chosen title before I had finished the talk, but what I realized is that the more things change, the more they stay the same. And you'll see this a lot with monkeypox as far as the reemergence and why we're seeing the reemergence. These are kind of very well-defined and very consistent fundamental drivers of emerging infectious diseases. With this current outbreak, changes in demographics and behavior, we've seen this with sexual networks and households. Environmental changes, again, that human-to-animal interface is getting smaller, being closer and closer over time. As far as breakdown of public health measures, there have been limited public health resources devoted and developed within Africa, which obviously has allowed this to be a neglected disease for many decades. I have questions about microbial adaptation and change, and I think that we'll learn a lot over the coming months about whether there is something that is different about the virus or some new tropism related to the virus. Unidentified reservoirs, we think this originates with small mammals primarily, but are there other ones that have not been fully sussed out? And finally, international travel. This is a small world. People are traveling a lot, even more so now that the pandemic has reached a different phase. So the challenge is real and hard to deny. 3 of 4 new or emerging infectious diseases is in zoonosis. So a disease that is transmitted from animals to humans. And zoonoses now contribute 2.5 billion cases and 2.7 million deaths worldwide annually. The barriers are formidable. The concept of exceptionalism, that this is someone else's problem and not ours until it becomes ours. This is one of the reasons why monkeypox has probably been neglected over the last 50 years since it was first diagnosed within that child in the DRC. Also, the concentration of resources. So it's really not a big issue, right? A lot of these diseases we've seen with Ebola, we've seen with other infectious diseases have not been an issue until they've hit a developed country. And then the concentration of resources, vaccine therapeutics within developed countries, and not to the point source where many of these diseases have caused significant infection and comorbidity and mortality over the last decades. Misinformation. I will tell you the story of a patient that I took care of in the behavioral health pod in the ED who had schizophrenia and basically came to me and said that they felt unclean and needed to be tested for monkeypox virus. It broke my heart to hear that. Just the amount of information about this disease, and finally the stigma. These are all formidable barriers, the stigma of race, sexual orientation, gender identity that has wrongfully been associated with the outbreak. Is there a way forward? None of this is old. None of this is new, actually. We need to develop local and diagnostic public health capacity. So I like to say one of my favorite sayings, at least within disaster medicine, is that all disasters are local. You really need to support the locals in terms of developing a response to a disaster, in this case, an outbreak or a pandemic for that matter. So improved diagnostics and public health surveillance. We need to identify reservoirs. We need to share data between countries on human and animal cases. We need to modify human situations and behaviors that increase the risk for spillover of viruses from animals to humans. And we need to push vaccines and therapeutics to where they are most needed and where they will have the greatest impact. And that is not always within the developed countries. And then finally, the important note here is that no one can do it alone. So inclusion, hopefully I have demonstrated that emerging infectious diseases are important to all clinicians, and they are certainly here to stay. We obviously continue to learn more about monkeypox with every day throughout this current outbreak. I hope that you will now acknowledge the past as prologue to this current moment in time. You now are able to recognize the signs and symptoms of monkeypox virus, and hopefully you will be able to use the tools available to protect yourselves as well as to treat your patients with compassion. And then finally, the important thing here is that we're all in it together. We've been through 2 years of pandemic. We will get through this current outbreak as well. And a nod to the fact that no one does it alone, I'd like to just say a quick thank you to all of our leadership, Dr. Powderly, Fraser, Dr. Adeoye, Dr. Shield, the many folks within the ID division, our STI group, Hillary Reno, Joseph Cherby, Abby Song, Flana Liang, who have contributed much of the education on monkeypox virus, our operations group, including Dr. Marshall, Babcock, Warren, Kwan, Durkin, and many others who work behind the scenes to develop processes and responses to the current outbreak, as well as the next one on the horizon. The original emerging infectious disease doc here at WashU, Steve Lawrence, the unsung heroes of all of our pandemics, outbreaks, infection prevention, OC health, pharmacy, emergency management, our emerging illness program. Finally, all the physicians, the fellows, the residents, and APPs, you hold the line when it comes to emerging infectious diseases. And then finally, our nurses, as well as support staff who are the backbone of healthcare, and many more. And with that, I thank you for your time today, and I'm happy to take any questions.
Steve, that was a really terrific talk. I think we have time for a few questions from the audience. And then Stephanie, are there questions from the chat also that we should pull in?
Here, trying to open from my computer, we got that echo, so.
Great, thanks. So I'll start, Steve, with one question. So given the age distribution for folks who got smallpox vaccine, is there any data that actually really still is protective despite how long ago people got smallpox vaccine?
That's a great question. I don't have the specific data to support that, but it's been more than 40 years since the end of eradication of smallpox and probably the administration of smallpox vaccination in many places. So I have to suspect that the large majority of our population is probably no longer immunized or has protective immunity against smallpox. But there's probably are other folks within our division who could speak better to that.
Gary?
Well, there have been cases of people who have smallpox vaccine. My question though is, it's interesting, there's parallel, probably different reasons for it. But it's odd to me that the United States is, this started in Nigeria. We're not hearing about millions. We have big cities there. They have a lot of crowding. The United States is disproportionately affected by this disease as it was with COVID. Different reasons, but why do you think that is? Is that a pattern we're going to see with other emerging infections?
That is an awesome observation. And, I think if you look at the cases in Africa with the current outbreak, they're far lower than they are here in the United States. And this goes to emerging pathogens and kind of the different ways that they can accelerate in terms of transmission. In this case, with this outbreak, this has been tied with sexual networks, very close-knit networks that I think is very unique about this outbreak. And all these changes in behavior, unique characteristics of networks and so forth, probably contribute to this emergence here in the United States as well as Europe as well. But we will see different, potentially non-biological drivers for emerging infectious diseases for certain.
Steve, can you also address, there's a move towards getting away from geographic localization of naming of diseases. So you emphasize clade 1 and clade 2. And also the WHO is trying to get away from the term monkeypox. So can you address why, in terms of health equity, people should understand the reasons for those nomenclature changes?
Oh, absolutely. That's a big thing that we need to be aware of is that these names, as well as geographic locations, can drive a lot of misinformation, misperception of a disease. Certainly, I felt it very personally during the first couple of weeks of COVID-19, as this was considered potentially an Asian disease, more so, certainly not anymore. But as far as the naming of a disease, as well as how you depict it within popular media, there have been lots of comments about the fact that the media has basically shown pictures of young African children with devastating monkeypox virus presentations from the DRC. That's a very different disease than what we're seeing here, obviously here in the United States, but as the image that's being portrayed and being promoted within popular media. And I think that having that geographic association with a virus, or having, in this case, a name that probably, when it was first named, when it was first identified in the 60s, it probably was, I think it was probably because of its association, right, with this incidental host, monkeys that were within zoos and research colonies and so forth, and really just not really thinking about the potential impact and associations across continents and demographics that would result from that. So there needs to be a change in the nomenclature of the virus. It is moving forward with the World Health Organization in terms of clade 1, clade 2, and I'll be interested to hear what they decide on terms of renaming the virus itself.
Any other questions here, Steve? I think there might be a couple questions on the chat.
So as far as a recording, I believe that there will be a recording both online with the school medicine as well as a YouTube channel, right? Yep. Okay.
It goes on the Department of Medicine website on their YouTube channel there, and it has a mesh heading for grand rounds and all the topics that the chief resident's so incredibly well organized by thematic domains and dates, so you can find current and past grand rounds. Any
Excellent.
other questions? If not, Steve, thank you.
Thank you very much. Onwards.